images. There is a rain fog outside, there is a brain fog, everybody is tired, half of them are eating, half of them are sleeping, and on top of that, the previous talk with the molecular ATCGs, all confused. All those alphabets, ATCG are running your brain. So to get up whatever 4, 5 people or 10 people around, let's move on how to treat these diseases with the MET amplification or MET Exon 14 skipping mutation. So as per the pathophysiology or the molecular biology of a disease, we all know these are all the transcellular proteins and their overexpression in the form of either amplification or certain mutation which leads to constitutive activation of the tyrosine kinase intracellular activities, and that's how the cell proliferates and it becomes immortal. So how to kill this cell before that or making that mortal? Let's see what is the pattern of this exon 14 skipping mutation or the MET amplification diseases. So they are more common in the older patients. Regardless of the history of smoking, they are present. They are around 1 to 3%. They are both seen in the female and the male patient. And a very particular finding about the MET exon is the concurrence with the PD-L1 expression. So the classic algorithm of testing of the molecular pathways for the lung cancer, I don't think we should be going with that. We have to do the MET or we have to follow the present guidelines. So in patients who are more than 50% of the TPS, 50% there is a possibility that the in those MET positive tumors, 50% of them will have the PD-L1 expression. If you compare the treatment with the standard of care of therapy with the chemotherapy, obviously it has a very poor prognosis, and if you treat them with the targeted therapy, the outcomes they are better. So this is the slide which shows that the comparison with the chemotherapy with the MET inhibitor. Obviously, the MET inhibitors are working better here as compared to the conventional chemotherapy. To understand this MET regulation, madam has shown you the entire gamut, but to summarize it, 3% exon skipping and 20% in the sarcomatoid variant. So when you get use a good biopsy report, so you must look for the sarcomatoid variant and ask for the MET amplification or exon skipping mutation. Obviously, the amplification is more important when you are having a resistance to the TKI. So in a second line therapy, you must see a post EGFR whether this amplification is happening or not. About the expression, there was a phase 3 trial on the basis of IHC. The drug used were onartuzumab plus erlotinib. That was absolutely negative trial. It was published in JCO. And that's how we have forgotten about the ISC testing of the MET. So let's forget about the ISC. We don't need the ISC. What we need is the amplification and the exon 14 skipping mutation. As ma'am has already covered, you should do it by the fish or the NGS. And these are the various therapies which are available as on date with us: capmatinib, tepotinib, crizotinib, or savolitinib. Other drugs are also in pipeline to get the approvals, or the studies are undergoing. This is the first study which has given the FDA the approval for the exon 14 mutated or the amplified. They are the phase 2 design published in the NEGM. They are multi-cohort studies in which basically the molecular pattern were divided, and both first line also and second line therapies were also, patients were included. These are all the waterfall plots showing the various patients in which the response rate, overall response rate, was quite impressive. And to summarize again, almost 68% patient had the response, overall response rate in the cohort B, that was the patients who were treatment naive. Those patients were pre-treated, the response rate is around 40%. So these are the efficacy points. And when you're taking the only MET amplification, these responses were shorter. So the percentage of the patients who were previously treated in the MET amplification patient, this figure was reduced to 30%, and this has come to 40%. So the responses are better with the exon 14 skipping mutation MET positive tumors. The next drug comes is the tepotinib. The beauty of this trial, which was published in NECM, is almost 65 patients were diagnosed on the basis of the liquid biopsy. Around 90 patients were on the tissue biopsy, and equal number of the patients were there on the both liquid and the FFPE samples analysis. This is the study proforma, and due to short of time, we'll just skip some of the slide. These are some characteristics of the patient. Asian patients were included in this vision study. And those patients who are treatment naive, like capmatinib, the tepotinib also had shown a good response rate. The duration of response rate, the median is 15 months. And the PFS was around 15.9 months, and overall survival was almost reaching up to 90 months. So there we also saw around 68% of the response rate. Here also around 58.6% of the overall response rate. So when you are using the first line therapy, either with the capmatinib or the tepotinib, the responses are quite good. They are crossing the benchmark of the 50%. These are the patients who are previously treated. Obviously these figures are coming down, and it is around 50%. This figure is around 40% in capmatinib trial. So when you compare, I will come on those slides subsequently. There is a slide to show for Asian patients were included in these trials. And to just summarize here, these are the published trials of the crizotinib, cabozantinib, capmatinib, tepotinib. The crizotinib overall response rate, when there are patients on the first line, they are 32%. Cabozantinib, yes, it has some effectivity, but somehow the overall response rate around is 10.8%. And capmatinib and tepotinib, I already mentioned about it. There are the classic trials which have been done in the MET. The dose of tepotinib is 500 OD, capmatinib 400 BD, and the crizotinib as conventional. There is a drug known as sovleplenib, though it's not available in India, but it has shown the similar efficacy. So do we have any analysis which shows that one drug is better than the other? I think these are the, there is some analysis which was published, but what I think is they're all hypotheses generating results, but somehow the study are more in favor of the tepotinib when there is a match adjusted analysis is done, and in that it has shown that in the second line, possibly the tepotinib is doing a shade better. But again, it is more of an exploratory design, so unless we have head-to-head comparison, it's very difficult to comment. Anyway, this is a difference between geometry and the vision. Is a brain metastasis. Both the drugs, they have good CNS penetration, and capmatinib and tepotinib, they have more than 75% responses in the brain and durable responses in the brain. So this is the NCCN chart, wherein both the capmatinib and tepotinib mentioned as a first-line therapy. One word about the MET amplification, and in the analysis of the MET capmatinib trial, they have done some exploration wherein when you do the response analysis and the ratio is more than 2, the responses are around 44%. When it is less than 2, it is 22%. Similar to that analysis, the ISC also has shown differences in the response as per the then it comes to the crizotinib amplification. Same in the crizotinib trial, they have done the FIS testing, and when the ratio is more, the responses are better, the PFS are better. Safety, they are quite safe drug. Very important side effects are the pedal edema and rise in the creatinine. Rest regular like nausea, vomiting, are part and parcel of many drugs. But for creatinine monitoring has to be done because there is some expression of the MEK and MEK-B receptors in the kidney, which are those transporter proteins, and this drug is also inhibiting these receptor in the kidney. So you have to monitor serially the creatinine. These are some of the headlines and some pathophysiology behind science behind the side effects. One word about, again to be finished before that, about the PD-L1 expression. If so much of PD-L1 expression is high, does addition of the immunotherapy with the TKIs leads to better responses, but it's trials are underway. So in future we are going to go know about this. But at this moment, addition of the immunotherapy is not the choice, and the immunotherapy, when you compare with the TKIs and the chemotherapy, it is not a good option for this particular disease. As on date in India, we have all these three options available. Tepotinib, as per the 1+1 PAP is there, the monthly expenditure is around 75,000. And capmatinib, I think the PAP was there. I believe they are continuing or not. The info is not available. And when both cannot be offered, then obviously the crizotinib remains the treatment of choice. So conclude here, 1 to 6% of the patients might have this kind of aberration. One thing which I have not covered in the slides about the tepotinib trial, in that they have done the NGS for the tissue and the blood. In the blood also they could found that the mutation in the other pathways like PTN, RAS, NRAS, KRAS, and PIK3 pathways. 2 to 3%, overall 10% of the mutations were found in the RAS or PIK3 pathway. If those mutations are present, tepotinib is not working because all they are the downstream mutation. So we have a liquid biopsy report in your hand. Please look at the detailed report. Possibly you might have to do something more when you're treating this MET amplification when they have concurrently the other report. So this is what MET we have to remember, and my flight has got cancelled. So somebody who wants to meet me, I am free. Okay, so here onwards. Thank you very much.